Alrighty, so today I'm going to talk about cystic fibrosis. This is just kind of an overview and nurse management. So, what is cystic fibrosis? It is a fatal autosomal disease in which the patient inherits a defective copy of the cystic fibrosis gene. And so, what that defective gene then does is it affects multiple body systems and exocrine glands of the respiratory tract, GI tract, and reproductive tract. It can affect both adults and children, and on average, it affects about 30,000 people in the United States. Uh, it affects, or whoops, it's one of the major causes of severe chronic respiratory disease in children, and typically it's diagnosed by the age of 2, but it also can be diagnosed later in life. So the pathophysiology. So the pathophysiology is cystic fibrosis results from the mutation or dysfunction of the protein cystic fibrosis transmembrane conductive regulator, or CFTR for short. And so, what this protein does is it allows for the transport of chloride ions across the epithelial cell membrane. So, essentially, what that means is that the mutation causes thick, viscous secretions inside of multiple organs, such as the lungs, pancreas, liver, intestines, and the reproductive tract. So what we see with the respiratory tract is obviously, since there's that increase in those secretions, it's going to make it harder for the lungs to clear those secretions, which then can obviously lead to chronic respiratory infection, tissue damage, and if it gets worse enough, it could lead to respiratory failure. And then with the pancreas and like the intestines, cystic fibrosis can affect the nutrients and how they're absorbed. So this can lead to like malabsorption of fats, proteins, and carbohydrates, which then can cause poor growth. And since cystic fibrosis does affect those chloride ions, it can actually affect the ability to transport chloride ions, which then leads to an increased excretion of salt content in the sweat glands. So basically, what that means is that someone who has cystic fibrosis, when they sweat, they tend to sweat out a lot of sodium, which then, as we all know, if you lose a lot of sodium, it could lead to, or sweat a lot, you could lose a lot of water, so that could lead to dehydration, and it could also lead to hyponatremia. So this is a nice picture that I found in one of the textbooks, and it pretty much just sums up what I talked about on the last slide. So at the very top, you can see there's that CFTR mutation, which then affects the chloride as well as the sodium and water absorption. And then obviously that affects the other parts of the organ systems. So like this is primarily focused on the lungs, but it'll lead to that abnormal thick respiratory secretions, which then leads to defective mucus clearing, which then can lead to chronic airway obstruction, bacterial infection. Since there's now a bacterial infection, obviously our neutrophils are going to be increased, and then obviously over time it's going to lead to, like I said, respiratory failure, chronic bronchitis, and bronchiectasis. So how do we prevent cystic fibrosis? The easiest way to prevent cystic fibrosis is pretty much to do our routine screenings, because there isn't an actual treatment or prevention option yet, other than really just identifying it early and catching it. So things like genetic counseling and genetic testing can be used. So with genetic testing, we're going to once again be identifying those who have the cystic fibrosis gene, and also see who is potentially at risk for gaining that cystic fibrosis gene. So people who are heterozygous, which means they have one defective gene and one normal gene, so one normal gene and one mutated CFTR gene, don't actually have cystic fibrosis, but they are able to pass down cystic fibrosis to their offspring. And so if you think about it, if both parents are carriers or heterozygous, their offspring have about a 1 in 4 chance, so 25%, of developing cystic fibrosis. So how do we diagnose cystic fibrosis? Pretty much the first thing we're going to obviously do when they come in, we're going to do our health history and our physical. So obviously with the physical, looking at any presence of respiratory and GI symptoms is generally a good indicator. First, we're going to then obviously try to get a family history. We're going to want to perform DNA testing in prenates and newborns. More specifically, this is known as a non-invasive CFTR analysis. And basically what this does is it just helps determine the carrier status of the parents and see if the infant is at risk or could be suspected to have cystic fibrosis. They could also perform a sweat chloride test, and as the name implies, it's going to measure how much chloride is inside the sweat, because like I said in the slide before, they're going to have increased chloride secretion. So typically when they do this test, anything that's greater than 60 milliequivalents is a pretty standardized and surefire diagnosis of cystic fibrosis. And just kind of as a like a reference point, typically not people who don't have cystic fibrosis, when we sweat, we typically lose anywhere from 10 to 35 milliequivalents of chloride. So people with cystic fibrosis, they can be anywhere from 6 times to double sweating out chloride compared to the average person. We can also get chest x-ray taken, and that's going to help show hyperinflation, bronchial wall thickening, infiltration, and potentially atelectasis if it's severe enough inside of the lungs. And then we can also perform a pulmonary function test, or a PFT, and that's going to show a decreased forced vital capacity, a decreased expiratory volume, and increased residual volume due to obviously having those secretions in the lungs. Signs and symptoms that we're going to see, so with the respiratory, we're going to see cough, some sputum production, wheezing, fine or coarse crackles upon auscultation, chronic reoccurring respiratory infection, and chronic bronchiolitis and chronic bronchitis. With the skin, we're going to see that salty skin, obviously due to that excessive chloride sweating out, jaundice due to liver abnormalities, clubbing in the fingers and toes. With the GI, we're going to see some blockage potentially of the intestines, some abdominal pain due to that blockage, diarrhea, maybe some constipation, and obviously due to that malabsorption of nutrients, we also might see weight loss, or we could potentially see weight gain. With genital urinary, for both male and female, we can see some infertility issues. And with the pancreas, we're going to once again see some poor absorption. And actually, diabetes has been found to be somewhat associated with cystic fibrosis. So people who have cystic fibrosis are actually at risk for developing diabetes. So here's just another visual for those another picture for those visual learners. And so figure A is kind of what I just talked about in the slide before. So it's kind of showing signs and symptoms in the organs affected by cystic fibrosis. So like your sinuses, lungs, skin, liver, etc. But what I really like about this picture is figure B and C. So as you can see in figure B, that's your typical normal airway in someone who doesn't have cystic fibrosis, your quote-unquote normal airway. And on the bottom is your cystic fibrosis airway. And as you can see, in the top picture, the airway, it's wide, it's open, there's nothing potentially blocking the airways, so it's obviously allowing clear and adequate oxygenation, whereas on the bottom you can see that mucus has narrowed the airways, which is then going to make it harder for the patient to breathe. And obviously with that mucus that's obviously being sticky, which is causing that narrowing of the airway, we're going to see more bacteria kind of clumping and getting into that mucus, causing those bacterial infections. And we also could potentially see some blood in the mucus. So assessments, what are we going to be assessing? Obviously, we're going to be performing our respiratory assessment. So looking and observing things like the respiratory rate, the effort, depth, use of accessory muscles, any cough, if there is a cough, frequency and severity, is it productive, is it non-productive, observing any sputum, so doing our COCA, our color, odor, consistency, amount, any signs of barrel chest, cyanosis, respiratory distress, Auscultation, upon auscultation, we're going to hear, it's going to be diminished sounds, finer, those coarse crackles, potentially inspiratory and expiratory wheezes. Upon our skin assessment, we're going to see, obviously, once again, that cyanosis, once again, jaundice, um, clubbing in the hands and toes, edema, JVD, or it could be the opposite, our signs and symptoms of dehydration. So like poor skin turgor, dry mucous membranes, cracked lips, cold extremities, diminished peripheral pulses, stuff like that. And then we're also going to want to look at vital signs. So, we're going to see a slightly maybe elevated fever, either from dehydration or maybe a respiratory infection, tachycardia, tachypnea, a low SpO2. Typically, blood pressure isn't affected by cystic fibrosis, but obviously, any underlying or other medical conditions could alter the blood pressure. We're going to want to be noting any level of conscious changes and notifying the provider about that. And if it's a child, we're going to want to be looking at their age and development, as well as doing a caregiver assessment. And what a caregiver assessment is it's pretty much looking at the caregiver's knowledge about the disease. So things like the risk factors associated with cystic fibrosis, proper diet, proper exercise, signs and symptoms, observation of the disease and progression, maybe family history, just kind of a general and seeing if they know about the disease itself. So some nursing diagnoses with cystic fibrosis, we have impaired gas exchange, ineffective airway clearance, imbalanced nutrition, less than body, risk for dehydration, risk for infection, and deficient knowledge. So what are our priorities? So obviously our main three priorities are going to be maintaining that patent airway, getting rid of those secretions, and preventing any infections from occurring. And just more on the side, but are still a priority, we're going to want to be maintaining their growth and adequate nutrition, coping, anxiety reduction, education, and prevention of complications. So what are some interventions that we're going to be putting in to help clear and maintain that airway? We're going to obviously be doing our basic respiratory interventions, so things like raising the head of the bed, using the incentive spirometer, coughing and deep breathing. We're going to obviously increase their fluids because that's going to help thin those secretions out, along with just increasing the fluids. The doctor could prescribe mucolytic agents, which are also going to help thin those secretions if the fluids aren't thinning them enough where they're getting out. We could provide humidified oxygen if their SpO2 is low. The reason why we're going to want to do humidified oxygen over regular oxygen is that the humidified oxygen, the heat and the humidity actually is going to allow the secretions to essentially move a lot easier. So then it promotes and makes it easier for the patient to hack out those secretions. Chest physiotherapy and vest therapy are both really good. So that picture on the top, as you can see, is a vest that they use for vest therapy. And basically, so what it does is the patient's going to put on that vest, and then it gets connected to the machine to the right of it. And what it's going to do then is when it gets turned on, it's essentially going to vibrate and shake the chest of the patient, which is going to then allow those secretions to get broken up into smaller little pieces, which then allows the patient to get rid of those secretions a lot easier. Those two interventions, they work very well when it comes to help reducing and getting those secretions out of the body. Another thing we can also do is, so we can provide suction. So that other picture on the right, on the bottom right, is one thing that I typically see in the hospital. So we're going to hook it up to the wall, and either the nurse or sometimes the patient themselves can suction themselves. So obviously if the patient is coughing and they're trying to hack up those secretions and it's like stuck in the back of their throat, we can get the suction and help eliminate and get those secretions that are stuck in the back of their throat and they can't just get it out, even though they're coughing up. They're continuously coughing, just trying to get rid of those secretions. So preventing infection, we're going to be wanting to monitor our patient's vital signs. So things like fever, tachycardia, tachypnea, looking at signs and symptoms of infection. So like fever, diaphoresis, cloudy urine, frequent small urinations, yellowish green sputum, muscle aches. More specific to a respiratory infection, we'll see things like a sore throat, runny nose or nasal congestion, headache, shortness of breath, and sinusitis. We're going to once again encourage that cough and deep breathing, as well as adequate hydration to obviously once again thin those secretions to reduce the risk of infection. Labs, obviously, we're going to be monitoring our white blood cells, infection control, so proper hand washing, aseptic techniques, things like that, and then antibiotics. So with antibiotics, we're going to try to get a sputum sample before or at least during their stay, because that's going to help identify what kind of infection the patient currently has. If they can't get enough sputum out at first, then we can put them on just some broad spectrum antibiotics. And then once they actually do get a sputum culture, then we might narrow down our antibiotics so it specifically targets that infection. And then obviously education, so things like infection control, how to reduce infections, and then signs and symptoms of infection. So maintaining growth, if we kind of go back a couple slides ago, I brought up that cystic fibrosis doesn't only affect the respiratory system, but it also can affect the pancreas and the intestines related to malabsorption of fats, proteins, and carbs. So with that, we're going to want to be making sure that we're monitoring the patient's growth. So, every time they come into the hospital or the clinic, we're going to want to take their height, their weight, and their BMI just to see are they properly growing. We're going to want to look at their diet. So, are they eating foods that are rich in vegetables, fruits, high in calories, high in fiber, high in protein, high in fat, and with diet, this is more so under education, but we're going to want them to eat more smaller, frequent meals and potentially snack throughout the day. Because if you think about it, if they have a respiratory issue and they're having a hard time eating, it's kind of like your COPD patient, where if they eat longer meals, that's going to take up more energy, which is going to make it harder for them to breathe over time. So doing those smaller, more frequent meals is going to save more energy and consumption. Adequate sleep obviously is going to depend on the age of the person. Younger adolescents, we're going to typically want to see 8 to 10 hours of sleep. Adults, more around 7 to 8 hours of sleep. We're going to want to make sure that they're exercising frequently, and also including rest periods as needed. So, 30 minutes a day at the minimum. We want to make sure that they're getting up and moving, because it's going to help get rid of those secretions and just help promote body growth and like bone structure and density. And then monitoring I&O is going to be important, especially because they might be sweating, so that's going to put them at risk for dehydration. And obviously, since they have that pancreas and intestines issues, they might have trouble passing like stool, or just not getting enough nutrition that we don't notice it. So effective coping and anxiety reduction, obviously, in order to reduce anxiety, we're going to want to do some age-appropriate activities. So, if it's a child, we're going to want to make sure that the caregiver is present, because they're going to kind of help make it so that the child seems safe and that they have someone there that they can trust. Obviously, using toys and dolls to help convey and show like a diagram of what is going on inside their body and what the treatment team is going to be doing in order to make them feel better. Health literacy, because you're not only going to be teaching the patient or the child, but you're also going to be teaching the parents. So making sure that you're using language that they both can understand, giving adequate time to ask questions and concerns. That's going to help reduce any anxiety, because it's going to help them kind of know what's going on with treatment. And then therapeutic communication is kind of pretty much what I just summed up. So, what are some potential complications that can occur? We can see hypoxemia, chronic or recurring lung infections, bronchiectasis, pneumothoraxes, heart failure, salt loss syndrome, and that's where the body loses sodium rapidly, which then is going to put our patients at risk for hyponatremia, diabetes, pancreatitis, liver disease or liver failure, and potentially depression and anxiety. So, what are some collaborative treatments? We have our chest physiotherapy and our vest therapy, which I kind of brushed on earlier. Mechanical ventilation, it can vary. Obviously, if they're more on the hypoxic side, we're going to give them the CPAP or BiPAP. And if their airways aren't staying patent and open, then we may have to do more so of a tracheostomy or an ETT. An NG may be placed to help with nutritional needs. Bowel surgery, it's really more specific to if the patient is exhibiting those certain signs and symptoms. But if a blockage develops in the bowels and they're not getting enough adequate nutrition, they may do a bowel surgery. In severe cases, they may do a lung transplant, and also in severe cases, they might do a liver transplant. But that's typically only done if there is severe damage by like liver disease or cirrhosis. And then if anything does happen, or just in general, it's nice to have some pulmonary rehab if needed, because that's going to obviously help strengthen the patient and their lungs to kind of get back to a normal life where they can perform their activities of daily living and not feel like they're having a harder time breathing. So medications that we're going to typically see, obviously I kind of brought this up earlier, antibiotics. So we're going to start them on that broad spectrum until we get that sputum culture. Typically they're going to be given orally, IV, or through a nebulizer. IV, typically inpatient, and then we'll send them home on orals. Corticosteroids we're going to be using to obviously decrease the inflammation inside of the airways. Bronchodilators are going to help open up and dilate the airways to help improve oxygenation. Mucolytics, once again, to help thin those secretions to help get them out. CFTR modulators, this is a medication that's essentially specific to cystic fibrosis. And what these CFTR modulators do is they help improve the function of that defective CFTR protein. Hypertonic saline, we're going to be giving that through a nebulizer. And what that's going to essentially do is it's going to thin the mucus, kind of like a mucolytic, and it's going to make it so the patient is able to cough out that mucus a lot easier. Supplemental oxygen, once again, we're going to want to go more towards the humidified to obviously help move those secretions and get those secretions out of their body. And I found this interesting. In an article that I read about, it was found that NSAIDs, ibuprofen in particular, was actually shown to slow down the loss of lung function in children between the ages of 6 to 17 with cystic fibrosis. They trialed it with adults, but there really wasn't any significant research or data to back it up, but only in children, which I thought was interesting. And then finally, supplements, obviously, as needed. So we may have to give them vitamins like A, D, E, and K, sodium if they're hyponatremic, pancreatic enzymes. That's another one that's specific to each patient. Planning and goals, obviously, the patient's airway is going to remain patent. They're going to be able to clear those secretions, have adequate oxygenation, no infection is going to be present, adequate fluids and nutrition, being able to cope and make lifestyle modifications, reduce anxiety, remain free of complications. Pretty straightforward stuff. Education then, obviously we're going to educate the patient on the disease process, signs and symptoms of the disease, what medications we're going to be giving them, why we're giving them those medications, side effects of medications, if they smoke, advising them to quit smoking to help reduce the irritation and inflammation, and then some lifestyle modifications. So once again, mainly like diet and exercise. So making sure we teach them, we let them know that exercising does have its benefits. It's going to help improve the airways, improve the bone density, muscle strength, and then and then diet's going to help with growth. Infection control, things like proper cleaning, aseptic techniques, hand washings, signs and symptoms of infection, diabetes education if applicable, because like I said earlier, cystic fibrosis can have diabetes associated with it. And then things like when to call the doctor. So they should call the doctor if they have a pulmonary exacerbation. So that's like an increase in coughs, wheezings, any chest congestion, and excessive weight loss, poor appetite, fever, if they're coughing up any blood, or if they have any sudden shortness of breath or chest pain. And then when we discharge them, we're going to want to educate them on routine checkups. So with routine checkups, it's obviously going to be part of the follow-up treatment. The frequency is really going to just depend on the age. So obviously the younger the patient, the more frequent they're going to schedule the visits. But on average, it's going to be anywhere from every 3 months to annually. And so what's going to be monitored inside of that checkup is they're going to look at their height, weight, BMI. Are they staying active? What's their diet like? They're going to do their physical head to toe, their psychosocial assessment, and then they're going to do any follow-up education that may be potentially needed with that patient. And that is all. Hope you guys have a good rest of your day.